Yeah, hello. My name is Dr. McKenzie. I am a chiropractor that specializes in neurology. Today I'm going to talk about concussions, and this is going to be the long version of what happens with concussions. We're also going to have a short version, so you can pick which one you like to watch. Also, these are going to get updated as constantly as I learn more information, so that everything will be as accurate as possible. But what I'm going to do is I'm going to talk about, a lot of people don't even know what concussions really are, and they don't realize how important it is to, to evaluate and receive the proper care for concussion. And it's, in healthcare, there's very few of us that really understand concussion. So a lot of people are really not getting properly evaluated and treated for concussions. So what is an actual concussion? A concussion is an altered mental state after a traumatic brain injury. So can you have, so here's the question, can you have a traumatic brain injury that's not a concussion? And the answer is yes. I would recommend getting evaluated even for all forms of traumatic brain injury. But concussions can lead to something called diaskesis, which is an indirect problem from the injury. Gliosis, which is where the glial cells, these are cells in the brain that clump and take up space but do not assist in the recovery process. And then we also see atrophy. So depending on what areas of the brain are injured and how severe the injury is, those areas of the brain will actually atrophy. So that's why we need to really be looking at these things, because it can affect the quality of our life and our ability to function for the rest of our life. And this is the most common cause of death in patients between the ages of 1 and 45. And we see about 150,000 actual deaths per year. I think these are actually underreported, because since clinicians are not as aware of what concussions can do to people, I would bet you that the number is probably double. And I even lost my own son last year from having 2 concussions close together that were severe. So with concussions, we are going to see different kinds of amnesias depending on the type of concussion sustained. And sometimes these types of amnesias are just very temporary, and sometimes they're long-term. One type is post-traumatic amnesia. And this is where you have impaired recall surrounding the time of your actual injury. Retrograde amnesia is where you forget things that happened before the injury, and anterograde is where you have the inability to form new memories after the injury. So if you have the primary aspect of the injury that's involved is anatomical and physiological. These are basically what we see with a primary injury. We get forces that may cause distortion or shearing or vascular injury, as well as destabilization of cell membranes and membrane actual destruction. So what we're saying is that the actual nerves get injured in the brain, and we're not getting enough blood now to certain areas of the brain. Then after that primary insult, what starts happening within sometimes hours to days or even weeks is that we get increased free radical damage, which causes further degeneration in the brain. We get increased, it should say neuroexcitotoxicity, but basically what we're saying is that certain areas become way overactive because they're basically on fire. And we see that basically there's way too much glutamate activity in the brain, which causes microglial activation, which causes more glutamate, which causes more microglial activation. And then what we see is very significant degeneration in these areas. And what we also see, which is kind of interesting, is at the very same time, because of this kind of inflammation that happens in the brain, we see that the blood-brain barrier starts to become it's a barrier that no longer is completely separating these areas of the blood from the brain. And so it becomes leaky. And when this happens, the gut also becomes more leaky, and we'll start seeing issues like constipation. So the gut can affect the brain, and the brain does definitely affect the gut. We also can see disturbed ionic homeostasis. What does that mean? That means that the electrolytes that we need, like sodium and potassium and chloride and these kinds of things, start changing. We get the wrong concentrations, and this can lead to things like metabolic acidosis, which can eventually cause people to go into shock and can cause death. We get lipid peroxidation. Basically what we're saying is that the brain is mostly fat, and these areas start becoming damaged as well. So the fats themselves become damaged. Mitochondrial dysfunction. Mitochondria are the part of a cell that helps us make energy for that cell to work and for our whole body to work. And this is something that we inherit from our mother. The amount of mitochondria. So if mom has a lot of mitochondria, we're probably going to have a lot of mitochondria. If she doesn't have much mitochondria, we're not going to have as much mitochondria. And so a mother's health can affect the health of her offspring even more than the father's health. We get axonal disruption. That's where the long part of the nerve can become sheared or torn. And so now we're not going to get normal electromagnetic transmission inside of a nerve. And then all of this can lead to, of course, cell death. And also we talk about secondary ischemia. Ischemia is where we're not getting enough blood now to certain parts of our brain, which will cause further issues and damage. Some of the things that we see after a person's had a concussion are depression, dizziness, as well as poor balance, drowsiness, fatigue, poor concentration, headaches, sensitivity to light. People can become a lot more irritable. We see neck pain and symptoms of whiplash, especially the younger the patient. If the patient is 8 years old or younger, or if they happen to have a small neck and a large head, or if the patient has special needs and they don't have the ability to brace a fall, then they're going to have more noticeable neck issues as well. Usually the concussion will be more severe. Also, we see altered endocrine function. So, if we understand the endocrine system, we have to look at the hypothalamus, which is in the brain, and that regulates our appetite, our thirst, sleep and wake cycles, sex drive, temperature, all kinds of things are right there. And this whole, we call it the hypothalamic pituitary adrenal gut axis, is interrupted. And so it's really important a lot of times if we're going to rehab patients that have had a concussion to measure and quantify hormones, so we can take a look at what the levels are to see if we need to do things to change those levels, and also to stimulate that axis. A lot of times we see ringing in the ears, as well as numbness and tingling kinds of sensations, and that numbness and tingling can be in your face, or it could be in your arms, it can be in all the kinds of different places depending on where your injury actually is. So second impact syndrome. A second impact syndrome, this is where you had a concussion already and it was severe, and not enough time has passed for your brain to be able to be stabilized again. So you still have swelling in your brain, and now all of a sudden you get hit in the head again. So what we see here is that the ventricles of the brain don't drain as well, and this causes not enough blood into the brain as well. So basically the blood has been going to the outside of the brain, and so then there's not enough on the inside of the brain. This causes what we call diffuse cortical spreading. So basically, so the area that's injured now starts affecting the areas around it, and eventually this spreads to the whole brain, making the whole brain less able to function. And this leads to also something called transtentorial herniation, where we can end up with blood clots that are outside of the dura in our brain. So we call these epidural hematomas. We can end up with subdural hematomas. We can end up with subarachnoid bleeds. All of these things can happen. If somebody's had a second impact syndrome, or if something is like that is starting, the best thing to do is get them to the emergency room right away, get a CT scan. Actually, if you've had any kind of significant head trauma, a CT scan gives us the most information immediately. And usually, within a couple of weeks or a month, we should do a follow-up with an MRI, because that's going to show us other additional information. But the most important thing to do initially with a head injury is going to be a CT scan. So anyway, so with these second impact syndromes, we see acute cerebrovascular congestion and loss of cerebrovascular autoregulation. So what does that really mean? That means that we're not getting enough blood into the brain, and we're not draining that blood very quickly either. So we're getting a slowing and a congestion of the blood to the brain. This results in more swelling. So now the brain swells more, which causes even more problems. This can happen, so if a person's had, the way it's defined typically is that usually within 2 weeks after your first impact, but it can happen 2 months. Actually, it could be any time within about 1.5 years of an original severe concussion. So if you have anything within that period of 1.5 years or less, and of course the closer to that original injury, the more severe the outcome, but anything within that 1.5 years. So we keep getting that cortical depression that I was talking about, and we get excessive cortical impairment. So you can start seeing that there's personality changes, people are less aware of their environment, people become a lot more sleepy, and then we get increased intracranial blood volume, and it's because we said that there's a lot of congestion, and there's not even enough blood going to the brain, but because it's all swollen, the blood volume increases inside of the brain itself. So these are some of the symptoms of the second impact syndrome. The individual may appear dazed or confused, but remains awake, verbal and ambulatory. So sometimes, people can still talk, they can still walk, assuming that they could do that before the injury. But then they start developing a semi-comatose state, where they start becoming very, very sleepy, and increasingly they don't want to keep their eyes open. The pupils will start to dilate rapidly. So what we see with a pupil is, if I shine light on a pupil, it should be able to basically constrict and dilate. We call that hippus. When we lose the ability to have hippus, that's very, very concerning. What that means is that the reticular activating system of the brain, and that also runs all the way into our cord, we call it the reticulospinal pathway. This area has been interrupted, and so we see that with comatose states, and the pupils, they start getting really big, and they also don't respond to light, and that's a very, very concerning thing. And usually what that tells somebody in the emergency room is that it's at the very end of the patient's life. So we start seeing also limited spontaneous eye movements. So meaning that, you know, the eyes just don't even twitch anymore. Like sometimes when a person gets a head injury, their eyes will actually twitch a certain amount, and afterwards, as it gets to this point, they won't do that. We start seeing respiratory failure. So with this, we start seeing that people are taking very rapid, shallow breaths. That's a very, very bad sign. What that means by this point, sometimes with these head injuries, we'll end up with an area of the brain that starts to swell, and it will push into the lower part of the brainstem. It's called an uncal herniation, and it'll start affecting the medulla oblongata, and that's when this is the area that we see that affects our vagus nerve, and our vagus nerve actually comes from here. As this starts to fail, people lose the ability to, you know, basically their electrolytes are out of kilter, and they're just not getting enough oxygen now into their brain, and then we finally see death. So let's just talk about some of the different things that we get with TBIs. I'm just going to kind of define some of the things. With epidural hematomas, this is an extradural collection of blood. It has usually an arterial origin, and people need surgery ASAP. So if somebody's had a big giant head trauma, they should be evaluated and make sure that they're not developing this. I actually had a patient that was hit in the head by a frisbee, and her headaches became increasingly worse. This 3 years had already passed, and what she had was an epidural hematoma. So she had to get that fixed surgically, but she was living with it for 3 years. Subdural hematoma. This is now this is mostly a venous origin, and so if you look at the brain, it's covered by meninges, and the meninges, the outer part of it's called the dura. So a subdural means it's underneath the dura, so it's actually touching the brain, and epidural means that it's between the skull and the dura. So axonal or traumatic axonal injury, we see this. So there will be we see hemorrhage in the subarachnoid space, and this isn't something that you want to see, but this is another thing that we see, and you can see all this stuff on the CT scan. Interventricular hemorrhage. This is where we actually bleed into the ventricles. And then a contusion is also referred, and this, usually what we say then is that we get parenchymal hemorrhage. This is usually seen, this is basically a bruising of the brain. So we see it in both the frontal region of the brain and the temporal region of the brain. And what's really happening is we get rupture of the capillaries, which are the little tiny blood vessels. These areas actually rupture. And then the tissue tear hemorrhage. This occurs inside the brainstem and also the corpus callosum. The corpus callosum, by the way, is what connects the right side of the brain to the left side of the brain. And also the cerebellum is oftentimes damaged here. So these are all very, very significant. These are all things that can happen with any kind of a concussion, or even you don't even have to have a concussion. It can just be any kind of traumatic brain injury. So, you know, if you've been hit in the head hard, I just recommend getting checked right away. So let's talk about mild versus moderate versus severe traumatic brain injuries. So mild ones are defined by, this is about 30% of the cases. They develop post-concussive symptoms that usually start between 7 to 10 days after the injury. But, this is the most common form. It's 75%. It's accompanied by 30 or less minutes of loss of consciousness. We see dizziness, inability to concentrate, nausea, and decreased motor function. So they're not going to want to move around or do a lot. They usually recover within 2 weeks and sometimes up to a month. So, this is what a lot of football players get. They get hit hard, they get kind of knocked out for a little while, and they tend to recover, but none of these things are good. Oftentimes they get macroscopic intracranial abnormalities such as nosebleeds, seizures, neck pain. They can get vertebral basilar artery insufficiency and repeated vomiting. And so I'm just going to move on to the next part here. Athletes, this is the standard of care, which I don't agree with, but I'm going to tell you what it is. Athletes can return to the sport 1 week to 1 month if they've had only one concussion in the past history. Repetitive blows to the head increase the risk for concussion and chronic brain encephalopathy. There is that movie called Concussion with Will Smith, and they talk about chronic brain encephalopathy there. But these guys that play football and they get hit and they get hit and they get hit and they get hit, these things add up over time, and the outcomes are not very good. In my opinion, if you're going to be a pro athlete, you should get paid a whole lot of money if you're going to get hit in the head a lot, because it's going to affect the rest of your life. Helmets, by the way, in football don't prove to decrease the actual risk of concussion. So I think that it helps prevent fracture in your skull, but as far as your brain getting jolted around, it doesn't have any known benefit. Okay, so children that are age 14 and below have the worst outcomes and recovery times, especially age 8 and below. But they have increased sensitivity to glutamate. Glutamate, it's a neurotransmitter that we all have, but if somebody's had a concussion, you don't want to give them MSG because that's going to increase their glutamate even more. Increased risk for potentially fatal cerebral edema. So you can still have the risk, and it does increase if the child is 14 or younger. Decreased ability to anticipate brace for high impact force. So children that are younger are not usually as able to protect themselves from an oncoming blow to the head. And so that affects their outcome. So when we're doing a mild TBI exam, we should look at pupils. We should look at cranial 4 and 6, those are in the eyes. We should look and see for alterations of gait. So we're going to see how they walk. We're going to do finger to nose testing, and we're going to look at rapid alternating hand movements, and we're going to do a neurocognitive exam. And the Glasgow Coma Scale is a very good way to do that, and that's what we can do as clinicians for our patients. As far as labs go, we should be looking at glucose levels, and we should run a metabolic panel to make sure that the electrolytes are not becoming off, because if they are, that's a very, very bad sign. And we want to get a non-contrast CT scan. Okay, so moderate and severe TBIs. Moderate, we're going to see drowsiness. They can open their eyes though, and they will have localized pain. They have a higher risk of deterioration compared to mild, of course, and they must be carefully monitored. 90% have impairments of some sort, but they can live independently. 30 to 40% have a good recovery, but this is bad news. But others get epilepsy and infectious diseases. So when we talked about that blood-brain barrier becoming interrupted, all of a sudden people start getting infectious diseases into their brain because things, bacteria and stuff like that actually get into the brain, and they start causing even more damage. So we should be looking for these things with our patients. If it's a severe traumatic brain injury, we worry about comatose state, and they cannot follow commands. They exhibit rigidity or decorticate posturing. What does that actually look like? It looks like somebody is extending backwards like this, and they can't straighten up very easily. Sometimes seizures will also present that way, and so if a person has seizures following this, it can resemble that same decorticate rigidity or posturing. We see significant structural and metabolic brain dysfunction, so we definitely want to order the same labs we would order with the moderate and mild. And there's a high risk of further injury and deterioration with these ones. So, you know, I think if somebody's had a moderate or severe TBI, I really believe that we should do the mesenchymal stem cell injections, because that should seal up that blood-brain barrier and help prevent further deterioration. I would say as soon as you have a big head injury, get a CT scan right away, and as soon as you're stable at the hospital, go and get a mesenchymal stem cell injection. All right, so imaging, we talked about for the acute phase, we want to do a CT scan, and that will give us really, really good information of what's happening with the blood in the brain. It's going to just give us the most information. For subacute phase, we want to go for an MRI, and for chronic, we can look at both. So anyway, these are all other options. You know, sometimes we can look at if we want to look at the vasculature, we can do an MRA. So there's all kinds of options that we have as clinicians to order. And so the way that I would help a patient with concussions, I would just try to do whatever I could to stabilize the brain and prevent further degeneration, as well as figure out exactly which areas are under-functioning, which areas are over-functioning. With patients that have had concussions, sometimes the best thing to do is just calm the brain down, because you know, what we could do for most patients therapeutically, sometimes you just can't do that with a patient that's had a concussion. Because they just can't handle that amount of stimulation, because their brain is very fragile. So, but what we want to do is get a good history. We want to look at the labs. It's very important to look at the labs. We do something called the neurotransmitter assessment form, so we can try to figure out which neurotransmitters are not working appropriately, which ones are there maybe not enough of in the brain. Because if we can change that, we can change physiology to some extent, which will change the outcome. We do something called a brain region localization form, where we can tell based on your symptoms what area of the brain we're going to be assuming that we need to target especially. And then we do something called CNS vital signs. We can quantify the concussion and or the TBI and figure out you know, how bad is it, and we can remeasure it pre-treatment and post-treatment. At our clinic, we would do a quantitative EEG in-house, and we would actually look at what areas of the brain are under-functioning, what areas of the brain are over-functioning, and we can do something called neurofeedback, which helps the under-functioning areas to start firing at a higher rate, and then we take the areas that are working way too hard, and we try to dampen those. The thing about brains is, if an area is under-functioning or an area is over-functioning, that's not good, because both of those mean degeneration. And so we got to stop that, and then we want to start giving, and we want to give the brain what it needs therapeutically. So, you know, we're going to try to give you the good kinds of fats. We're going to probably give you supplements that is going to help with inflammation, increase mitochondrial output. There's actually supplements that can increase blood flow to the brain. These are very important when we're dealing with concussions. We have something called the neurosensory integrator, and that basically is a program where we have you come in and we have you do special exercises that are going to target the areas of the brain that have been affected with a concussion, and we can actually graph out your improvement, and we can make sure that you're actually improving. And then, you know, we'll talk about diet and exercise. Sometimes people need to have a diet that is healthy for the brain and anti-inflammatory. And so those are things that are really important. So anyway, the contact information, if you're interested in getting a hold of us and asking questions, this is our contact information. So feel free to contact me. Again, I'm Dr. McKenzie, and I'm a chiropractor that specializes in neurology, and my goal is just to maximize brain function of my patients. All right, thanks.